So we'll be discussing about the various aspects of precocious puberty in boys using a lot of these case scenarios, as well as the different aspects of evaluation and management in these regards, which becomes relevant from that perspective. So precocious puberty, as we were discussing, is something which is rarer in children as compared to the adult population, as compared to the female, in compared to the boys will have lesser chances of having precocious puberty. But once they have precocious puberty, there is a greater risk of developing a pathological cause in that regards. And that's something which is important to understand from that perspective. So we have this 5-year-old boy who presented with early puberty, and we can see clearly pubertal development was there. And there was a level of LH and FSH which were not elevated. So usually we expect this to be a central precocious puberty where you have a high level of LH and FSH. And when we found that the LH was low, the first possibility which we considered was obviously in line of an adrenal disorder, which was excluded based upon adrenal imaging, as well as a normal level of 17-hydroxyprogesterone. What was striking was that the HCG level was high, and this turned out to be a HCG secreting tumor. And this really highlights the importance in that perspective of identifying a pathological cause, because this then turned out to be a CNS lesion, a germinoma in the brain which was producing HCG, causing precocious puberty from that perspective. So precocious puberty in boys is less common compared to girls, but still 1 in 100 theoretically will have precocious puberty. The problem is identification is not that easy, because parents will come to us immediately if they notice any breast development or vaginal discharge. In boys, these changes will not be very, very evident, and that's why it is often not detected at the right time. A significant proportion of them, approximately half of them, may have a pathological cause, which is there from that perspective. So it's rare, but more likely to be pathological as compared to girls, and more likely to have a peripheral etiology as compared to girls in that perspective. All of you can go to have a look at our website, learning.growthsociety.in, which has got a lot of informative resources as well as courses which are there in terms of pediatric endocrinology, including our fellowship course and the pediatric endocrinology for postgraduate course. We do have frequent activities in the form of journal clubs, in the form of discussion PG lecture series from that perspective. There are publications including a basic, advanced, and protocol book, and a mobile app which provides guidance with regards to different aspects of pediatric endocrine disorders. So in this lecture series, we will be covering the pathophysiology, the etiology, and the assessment and management of precocious puberty in boys. And at the end, we will have very interesting Q&A session in which we'll try to cover whatever we have discussed. When we talk about the hypothalamic pituitary gonadal axis in boys, we know that there are 3 major organs: the hypothalamus, the pituitary, and the gonads. The GnRH, produced via the hypothalamus, the gonadotropin releasing hormone, which is a decapeptide, which has got 10 peptides, acts on both LH and FSH. So it's a single hormone regulating both luteinizing and follicle stimulating hormone. And these hormones will then respectively act on the Sertoli and the Leydig cell to produce AMH and testosterone. So testosterone production indirectly is controlled via LH and GnRH. This axis is responsible for development of puberty. Under normal circumstances, puberty is suppressed using inhibitory signals coming from the higher centers, predominantly converging in the form of GABAergic neuron and MKRN3, while there are stimulatory factors like glutamate and kisspeptin which play a stimulatory role and allow the onset of puberty at the right time in that perspective. Now, this testosterone has to be converted via 5-alpha reductase 2 to dihydrotestosterone, which acts on the androgen receptor, as well as getting converted into estrogen, which is responsible for epiphyseal growth. So the testosterone basically is a pro-hormone. It can be converted to estrogen and act on the estrogen-sensitive tissues like lipid and growth plate, or in terms of DHT, which will act on the androgen areas of the body. Now, the adrenal produces the DHEAs, which will then get converted into androgens, and it's responsible for increased production of testosterone. So in conditions where you have got a adrenal production or an extra testicular production of testosterone, the testicular size therefore will be small, and testicular size is a key clinical pointer in terms of evaluation, assessment, and management of precocious puberty. Now, as we've discussed, the LH is predominantly acting on the LHCG receptor on the Leydig cell to produce testosterone, while FSH is acting on the FSH receptor to stimulate the Sertoli cells to produce AMH. Now, the predominant cellular compartment in a prepubertal testis is largely the Sertoli cells, with small contribution from Leydig cells. And as puberty matures, the germ cells also become higher in number and size. So the size of testis is largely determined by FSH, while the testosterone production is really regulated by LH. So based upon differential expression of LH and FSH, we will have different clinical scenarios which may happen. So isolated LH excess or LH excess like states like the HCG producing tumor or testotoxicosis, you will have increased activity of the LHCG receptor, which is then going to act on the Leydig cell to produce more testosterone. You will have more Leydig cells, but since Leydig cells contribute to a small amount as far as testicular volume is concerned, the volume of the testis will not increase much. So you may have discrepancy in terms of the testicular size and the amount of testosterone which is being produced, and that may be the first clue of apparent excess of LH in that scenario. Now remember, girls do not develop precocious puberty if there is an isolated LH excess, because you need both LH as well as FSH to cause pubertal development in girls, while in boys only LH alone may be good enough from that perspective. Now, if we now look at in terms of the scenario in which your FSH action is more, typically in the setting of hypothyroidism, because TSH has a structural analogy as compared to the FSH receptor, it is then going to have a predominant effect on the Sertoli cells. So you will have large increase in the volume of the testis, but since there is no Leydig cells increased activity, you will not have higher testosterone. So you will have a discrepant scenario of large testis with no pubic hair. This is macroorchidism. This is analogous to the scenario of von Wieck-Grumbach syndrome in the setting of girls with prolonged hypothyroidism. This again, we will not really label as precocious puberty from that perspective. So just to recapitulate what I was talking about, in the prepubertal testis, the most component is Sertoli, followed by germ cells and Leydig cells. As the child becomes pubertal, the Sertoli cells become more. The Leydig component will be around 10 to 15%. And if we talk about the adults, we have got a much bigger 50% and above will be germ cells. And again, Leydig cell will be small. So isolated LH excess will cause increase in Leydig cell, but the testicular volume increase will not be that much. While if you have both LH and FSH elevation in the setting of a central precocious puberty, you expect the testicular volume to go up from that perspective. Now, the hypothalamic pituitary gonadal axis does have a significant change across the various parts of the perinatal and the postnatal period. So during the fetal period, the HPG axis is highly active. It then becomes very, very low towards the time of the term, and then there is a rapid rise again. And this is what we call as mini puberty. This mini puberty can last from around 6 months to 1 year. It tends to last longer in girls as compared to boys. So these are changes which we have to be wary about when we are doing those sort of evaluation. Subsequent to mini puberty, we expect the hormonal levels to be on a very, very low level, and this quiescent activity will be there throughout that period, which we notice during the childhood. Then we will have increased LH surges at night, followed by continuous LH pulses which happen, and then you will have an increase in testosterone level. So this is the normal development in terms of the puberty. And the first change which you can notice is if you actually monitor the LH pulses, you will see a nighttime LH pulse to be more, but otherwise the detectable LH will be the first sign of development of precocious puberty in boy. And you can look at morning testosterone, because this nighttime pulses are more, you will get an elevated morning testosterone, which becomes important from that perspective. And finally, you will have persistent elevation of the LH from that regards. So within the setting of the hypothalamic pituitary gonadal axis, we can understand that precocious puberty can largely be central or gonadotropin dependent precocious puberty, in which you will have elevated levels of LH and FSH, and you will have a larger testicular size. The most important condition in this group will of course be the CNS tumor, CNS pathology, as well as the idiopathic form. On the other hand, if you have a production which is independent of the gonadotropin, we are talking about a peripheral form of precocious puberty, which is characterized by low levels of LH and FSH and a pre-pubertal testicular volume. And therefore, testicular volume is the most important thing to look at in a boy with precocious puberty. Central precocious puberty can be because of a tumor, radiation, trauma, or insult. The chances of idiopathic one is much lower as compared to girls, where 90% or more will have an idiopathic form from that regards. The most common cause of peripheral precocious puberty is congenital adrenal hyperplasia, rarely adrenal tumor. And as we'll discuss subsequently, CAH is something which will present mostly with either a simple virilizing form or a 11-hydroxylase deficiency, in which you will have much severe virilization in that regards. McCune-Albright syndrome can have activating mutation of the GTPase, resulting in increased GNAS1 activity, resulting in precocious puberty, cafe au lait spots, skeletal abnormalities, along with thyrotoxicosis, Cushing syndrome, growth hormone excess as other manifestations. And isolated LHCG receptor hyperactivity will also result in a scenario of testotoxicosis. If there is exogenous testosterone, which may happen because of the application of gels which have been given, you may also have a peripheral precocious puberty. Hypothyroidism theoretically is not really a form of precocious puberty. It's basically a cause of macroorchidism in that regards. One may rarely have testicular tumors which can produce testosterone, and here you will have unilateral enlargement.